Good afternoon. This is Kate Cohn-Parrott. It's 12 o'clock right now. We are going to wait about 2 minutes to start the webinar. We're expecting a few more people, but we do have a great audience today with broad representation from all the various sectors within healthcare as well as social services. So looking forward to this webinar. Again, we'll kick off in about 2 minutes. Okay, so it's 12:02, so we're going to start the webinar. I appreciate all of your participation. We do expect a few more people to call in, but we don't want to abuse the time that all of you have put forward. And so we're looking forward to a great webinar here on telehealth. Nikki will be advancing our slides. So Nikki, could you please move to the agenda? Great, thank you. So I am Kate Cohn-Parrott. I'm the President and Chief Executive Officer of the Greater Detroit Area Health Council. Roger Piniella is actually our Chief Operating Officer, although sometimes he thinks he's the CEO, but just a joke there. Anyway, welcome. We think this is a very, very important and timely topic. We are well aware, and I think obviously most of you are very well aware because this is impacting your daily lives, on how telehealth has surfaced as one of the ways that our primary care providers, as well as specialists, as well as mental health providers, are able to treat and counsel and take care of their patients in today's environment. We have seen a lot of articles lately that talk about the challenges that our primary care physicians are facing. Some articles that even go as far as to say that in the next short while, we're going to see a 30% reduction in the availability of primary care physicians. And so being able to host clinical conversations and appointments through telehealth is very, very important. I know myself, I have personally had 2 telehealth visits in the last week and a half. So I never thought I would like it, but it's worked out pretty well. So we have a great team today. And so you can see the agenda in front of you. I'm going to take a minute or two to tell you about GDAC. And then we will welcome Dr. Jennifer Severe, who is a clinical assistant professor in the Department of Psychiatry at the University of Michigan. Dr. Severe is a clinician, researcher, educator, leader, and community advocate. She joined the Michigan Medicine Department of Psychiatry as clinical assistant professor after she graduated from the Public Psychiatry Fellowship at Columbia University. She is also a former awardee of the American Psychiatric Association Diversity Leadership Fellowship and currently serves as a consultant on the APA Council of International Psychiatry. Dr. Severe focuses on mood disorders and works in both the depression and bipolar disorder clinic at the University of Michigan Depression Center. We will then move to a presentation from MyHealth, which is the Michigan Health Information Network Shared Services Department, and they will be talking about telehealth, the way forward, supporting patients, the care team, and our healthcare ecosystem. We will first hear from Mary Graham, who is manager at MyHen Shared Services. Mary spent 5 years at Great Lakes Health Connect before bringing her skills to MyHen and is eager to continue her focus on provider-centered services supporting the care community, improving health and outcomes, and reducing healthcare costs. Mary is a licensed master social worker who started her career in crisis intervention. She has served as an adjunct faculty at Grand Valley State University and has extensive experience working in both behavioral health and with the developmentally disabled. In addition, Mary spent nearly 2 decades in managed care working with provider communities across Michigan. And then we also from MyHen hear from Kim Batchelder. She is the Senior Product Marketing Manager, Social Determinants of Health, e-consent, and telehealth. Kim comes to MyHen with 10 years of experience with the Michigan Department of Health and Human Services. Within her career with the state, she held multiple roles related to data sharing. Highlights include business delivery liaison for MDHHS Enterprise Technology, acting health information technology coordinating for Michigan, lead coordinator for the Health Information Technology Commission, and a member of the State Innovation Model Core team. Kim is driven in realizing business benefits by using health information technology and data exchange to improve user experience, quality, and cost efficiencies in various health and human settings. So we are going to ask that all of you can mute your speakers, your microphones while we go through this. We will first hear from Dr. Severe and then from Mary and Kim, and then we will open this up to Q&A. So we're going to do presentations first. Feel free to submit Q&A questions during the course of the presentations through the chat. After we get to the end of the presentation, we will also open it up for you to use your microphones and ask questions. Okay, so let me just give you a couple slide introduction to GDAC, and then we'll move on to Dr. Severe. So GDAC is a nonprofit membership organization. We lead collaborative efforts to address health and healthcare challenges. We serve Prosperity Region 10, which is Macomb, Oakland, and Wayne counties, including the city of Detroit. That's one of the zones in the state, and you can see that marked there. We are a regional healthcare improvement collaborative, and that means we serve as a trusted convener for those who get care, give care, and pay for care. Not going to go through the slide, but I just will point out that our mission is to work with our partners to empower and improve the health and outcomes, health and economic vitality of individuals, organizations, and communities. Again, doing that through collaboration. Next slide, please. So we partner with those who get care, give care, and pay for care, and we look to improve health outcomes. You can see on the left here, the groups of organizations and individuals that we partner with. And on the right, this gives you a flavor of some of the work that we are doing. We're not going to go through this right now. I could spend a whole webinar just talking about that, but we do some very important work. Next slide, please. Because we are partnering with everybody in the healthcare sector, I think we have a pretty solid grasp on the issues around COVID that are facing the sector. And you might see that we'll be looking at doing some webinars on some of these topics. On the left side in that turquoise kind of box there, or circle, you can see that we've highlighted adopting telehealth. That is certainly something that has been forced to the forefront of COVID. We're also been having a couple of webinars, employers only, looking at return to work issues. Next slide, please. So in addition to hosting this webinar, we've been pretty busy trying to address COVID. GDAC coordinated the delivery of 100,000 KN95 masks. I'm not going to go through the organizations who we provided those to, but we are pretty excited about the fact we were able to leverage our contacts and our networks to be able to do that. And for the most part, these went to small organizations who really didn't have the clout or wherewithal to go out and get those resources on their own. We have increased our focus on solving disparities. That's always been important to us, but it's really front and center now in what we are doing. We connected the University Physician Group with Ford Motor Company, who was able to donate 5 vehicles to support some drive to COVID testing. We have fundraisers available to help pay for masks. If any of you are so inclined to want to donate to that, we're again helping these small organizations and FQHCs to cover the cost of the mask. And we are hosting a variety of educational sessions. So that's where we're at, just a brief introduction to GDAC. And now we will move on and ask Dr. Severe, Jennifer Severe, to provide us with her presentation. Welcome, Dr. Severe.
Hi, thank you for having me. So I'm very excited to be here, and I think one thing that was I felt so connected with this topic because I felt that we're now seeing a change in the way people access to care and delivering care. And when we talk about telehealth, different aspects of it. And when you look at for best practices online, a lot of information will come up, and most of the time they look similar. But when you look at the day-to-day work, how we actually the uncertainties or unintended consequences or the benefits, pleasant surprise that we're getting with telehealth, I think it makes sense to organize this and put it together in a sense that I put it as a live document, for instance, at University of Michigan, where I ask everyone, this is what I'm noticing, what are you noticing? And please add every day to that document. And that's how I felt that I got a wealth of information of what we need to expect on a day-to-day basis as we continue to use telehealth that might not be posted online or that might not be part of the efficacy studies that are being done with telehealth. And next slide, sorry. So I thought talking about how we provide care and how we can continue to incorporate what we provide in an in-person visit in telehealth will be helpful. And on top of that, I thought also it will be interesting to diving into the scientific literature and come up with the benefits that are described, as well as unintended consequences, and frame that into a lesson learned to present today. And I think everyone had maybe already received the list of clinical recommendations and helpful tips that I had provided. And again, that came from the live document that I had distributed at University of Michigan and asked people to, report what they had noticed and brainstorm on ways to address those issues. So you may already have that document. If not, it will be also incorporated in my slides. Next slide. So yes, telehealth is changing fast, and as a result of the urgent need, we have to address the COVID-19 spread. The next speaker will talk more about what's been changing and some technical aspect and administrative aspect of telehealth. I will be mostly focusing on the clinical aspect, as I said, from the day-to-day practice. And there is a significant and important changes are happening, but those will remain after COVID-19. And we see at University of Michigan, I was one of the 3 psychiatrists to pilot telehealth in the Department of Psychiatry. And what we noticed was it was hard to get people to do telehealth. However, the whole Michigan medicine moved from about 4,000 video visits to 6,800 in March. From 444 in February to 6,800 in March, that was a huge jump. Many providers were not ready for this. And the effort that I had put in the last, let's say, 10 months to establish telehealth just out of proportion up. So I think that's a clear signal that the COVID-19 is really changing things, and things might remain the way they are, and I will change. I will show that in the next slides. However, one thing to keep in mind is, as I said, we are testing, exploring uncharted waters with telehealth still. and we will encounter positive changes as well as negative changes. And those will be framed in my presentation as benefits and lessons to learn. Next slide. So the World Health Organization doesn't make any distinction between telehealth and telemedicine, so it's the same concept, and the definition is simple: is any healthcare and services delivered remotely by the use of a telecommunication. So that can be anywhere from video conferencing using a laptop or phone, or it can be also phone messaging, phone visits. People just have their visit by phone without the video incorporated, and also mobile apps. So mobile apps are being used more now. We have their guidance for pain, guidance for psychotherapy, like cognitive behavioral therapy. There are guidance for self-care now, and right now I'm piloting the incorporation of mobile app has a self-help resources in primary care clinic at University of Michigan to see if we can augment that, the care that we provide, the mental health care we provide through the primary care doctors, if we could augment that with the use of telehealth in the form of mobile apps. But also patients are now also wearing Fitbits. They're wearing those devices where we can see how active they are, how many steps they make, the sleep pattern, you can track their mood. You can see also if they're having increased heart rate. Like I have patients, when they have panic attack, they will come in with a list of a chart of how fast they had the tachycardia, like the heart was racing when they were having this specific panic episode. So people are keeping track of things, and how much information we as provider we need to keep track of. And that's an answer that will vary a lot based on the care we want to provide and also the institution we're working with, and how much really we have capacity and time to incorporate those data. But people are gathering now data every single day with their device. So, and the interesting thing is telehealth is everywhere. It's in radiology, dermatology, pathology, and psychology, nephrology, so everywhere. So that means this is across the board, we'll be seeing the changes happening. Next slide. So again, when I'm diving into the scientific literature, I found a lot of benefits, and they're all almost similar. And those are benefits that are shared by patients, providers. So I decided to incorporate all three together. But the next slide will mostly show the top 5 benefits identified by patients. And I decided to put those separately because I felt that the care we provide to patients and the satisfaction they report, it's a key indicator of how much we're doing really a good job. Like the care we deliver, is it really compatible with what patients are looking for? But for now, when we look at these slides, you can see there is a lot of benefits for telehealth, and those are things that we've known even before COVID-19. The cost of care is decreased, and that itself is shown in internationally and nationally in terms of not only because patients access care earlier, but also it relates to all those benefits relates to each other. So the travel times and expense decrease for patients, for instance. They don't have to pay parkings, they don't have to put gas in their car to drive far away to go to a clinic. Missed appointments also generate more revenue for the clinic. I studied a new project at University of Michigan this past fall where I started asking the front desk, every time someone called and want to cancel their appointment, could you please offer them a video visit? See if we can turn that into a video visit. And that was something initially I thought was somehow ambitious, and I didn't know how much effort that I would need to put into this. But then I realized, the front desk realized it was an easy way to avoid no-shows and also miss appointments. And we can talk about that later on, but I think those are things that creative way that we can continue to use telehealth. And the other thing is sometimes, the wait times between visits matters, and we see a lot of studies showing that one of the reasons sometimes patients do not want to come to the clinic is the wait time, or they realize that not only the travel time, the time to park, but also the time to wait for doctors. Somehow, some way with telehealth, it shows that the wait time between visits had decreased. But not only the wait time between visits, but also the wait time to get an appointment also has improved. And because doctors have greater flexibility, they can work with lower support staff. They don't need a huge staff to be there to greet the patient, but they can do it from the comfort. Patients can do it from the comfort of their home, and providers also can do the same. And that in itself somehow reduces the wait time. And in rural or remote areas where some clinics, they have to wait to have a specialist come in to do the visit or to see certain patients, if those patients can be also connected remotely to this specialist, that itself also increase timely access. So to move to the improved section, so health outcomes, of course, improve because of all the reasons I listed here. The health services quality improve, higher connection with specialists remotely, access to care is timely, and even you can even have group visits. So something we had recently studied at University of Michigan was we used to have those group cognitive behavioral therapy, CBT group. So we realized that the basic group is mostly kind of a group where people gain skills and knowledge about CBT. So we thought that, well, maybe we can turn that into a class. So can we also continue to have those group visits through telehealth? And so far it's been smooth. We just started maybe a couple weeks ago. And again, I think those are new ways we'll be seeing people accessing group video visit together. And the other thing is medication adherence. That was interesting when I started asking patients. It's not unusual. We all ask patients which medications are you on? Are you taking it as prescribed? And one thing that will come up, sometimes patients either forget or they don't know exactly how many pills they have left. And I've seen my patients now coming with all their basket of medications and showing them to me one after the other. And one thing also I was able to do is when it comes to substance use, some of my patients overuse sometimes Klonopin, Xanax, and we sit together in a non-judgmental way and we go through those medications. How many pills do you have left? No, in 10 days you cannot have only, if you have used it just for 10 days, you cannot just have 5 left. You should have at least 20 left, something like that. So I think also telehealth somehow bring us closer to the patient experience in their home, but also help us to see, have a sharper focus on what they're using, the treatment we provide, and that also can help in terms of treatment adherence and compliance. Again, telehealth is used as a way of, educating, between providers. And one thing is Project ECHO. For some of you who's not, if you're not familiar with Project ECHO, it was started in Chicago where they have a panel of specialists, pain specialists, mental health specialists, and they provide guidance and support to clinics to primary care doctors and other providers who might need expertise and more skills in treating certain conditions. So they've been using telehealth for a while now, and nationwide, they've been using this tool to actually provide guidance and consultation to primary care doctors. We will be trying the Project ECHO in the Upper Peninsula to provide mental health expertise and consultations also to primary care doctors. So I'm looking forward to that. And the other thing is when it comes to telehealth, we know that increased communication, it's easier to communicate. There's a downside to that. I will discuss that later on, but again, we have a way to educate patients, increase their awareness, help them be more engaged and involved in their care. So all of that, I think those are great benefits of telehealth. Now, if we move to the next slide, as I said, I think patient satisfaction is a key indicator of how the work we provide, how well is it, how good is it. So when you look at the top 5 benefits on this slide, you will see that improved outcome. So first, this data came from 44 articles that they were looking across the board, like all the benefits reported by patients. And in 20% of the case, so improved outcomes, came first, and followed by ease of use, low costs, improved communication, decreased travel time. Interestingly, I thought decreased travel time will be what will come first, especially when we see patients coming from all over the place, driving for hours to come to our clinic. But you can see why improved outcomes really make a difference, because not only those patients have a way not to miss appointments, we make connected with the providers, easy access, but also when you look at the bigger picture, it comes at a cost for them. They're healthier, and healthier, we're talking about the public health impact. And I think mentally and physically, if they can have access to care, timely access, that really make a huge difference and drop everything else, the other benefits. So next slide. So I think this slide mostly encapsulates some of the day-to-day experience you will have with telehealth. And I think the reason I wanted to call it lessons to learn and not unintended consequences is because I wanted to put a positive spin on it. Initially, the first barrier to telehealth was doctor-patient relationship. However, I realized that once you pass a couple visits, people start getting comfortable, and it's not unusual to see patients and providers saying that this is no longer an issue. But I think it still remains, intimidating, and not everyone will be able to do a telehealth. And that will bring me to my second point, which is the clinical eligibility. How do you know someone can actually be a good candidate for telehealth? And especially if you're treating patients that you're not familiar with, new patients. I had one patient who came to visit about 4 weeks ago, and when she presented to the clinic, we had already started doing increase our video visit capacity for patients, but she was coughing and had a low-grade fever. So she was sent back to her car, and I was told that, well, they will convert it into a video visit, which I was fine with. However, what happened is she was not comfortable with the technology. So we had to do a phone visit. And that phone visit was painful in a sense that this is a complicated patient. I didn't have a sense of what was going on. She was not a good historian. She had a partner with her who was not a good historian. And she was reporting what could be a significant side effects from an injection of Abilify, an antipsychotic. So she was having muscle stiffness, sign that I would classify as extrapyramidal syndrome, EPS, in psychiatry. So she was there, and she insisted to do the phone visit because she was running out of her medication. Abilify was the only thing that worked so far for her, and she had her last injections 6 weeks ago, and she's supposed to get it every 4 weeks. So she wanted to have that injection. But in my mind, I couldn't see her, so there was no visual contact. I was on the phone with her. The story was somehow confusing. My diagnosis was not clear. So what I decided to do is to put aside the Abilify that has worked well for her and to go with a different antipsychotic, thinking that at the next visit, I will be able to appreciate better what I'm dealing with. Unfortunately, the second visit was also a phone visit because she was not comfortable with the technology. So I think, cases like this, especially when you're not familiar with patients, will be quite tricky. And that reminds me of before COVID-19, when I was helping with 2 other psychiatrists who were piloting telehealth. One thing that we really insisted on, and I would encourage you as providers also to think about, is initially we didn't want to see any new patients through telehealth because we felt that we should have this first initial contact, get a sense of who is this person and which diagnosis are we dealing with, and how build a rapport, and then start thinking for subsequent visit if this person will be a good candidate. However, with COVID-19, we had to change everything. So whether or not someone is medically complex, psychiatrically complex, we have to see them through a video visit first time. And I think also after my experience with that phone visit, what I did was I had to ask this patient to come in person for the 3rd visit, because at this point I realized I needed to augment my telehealth with some in-person visit, which is totally fine. So she came in and I evaluated her, and she was not the muscle stiffness. The stiffness she was reporting was mostly from chronic rheumatoid arthritis. So she has severe rheumatoid arthritis. So that means I could have continued with Abilify. So we decided to resume Abilify by mouth and PO. But it's just a way to, when you see those report, or when patients are reporting certain symptoms, are those false alarms, or is it really something we need to worry about? And I think the other part where one of my residents called me last week, a few days ago, telling me she was on the call with a patient who was suicidal. And at some point, she told the patient that she called 911 and they will come to her place. She wanted to double check her address. The call dropped. So the patient hung up the phone, didn't pick up back the phone. And I got paged at 7 o'clock at night to be informed of this. And I think one thing is, those things will happen. And sometimes call will drop out and you will start wondering and questioning, is this something I need to be worried about? Or is there anything else going on? And I think, you will see more in my clinical recommendations where I actually highlighted some of those issues and how to work around them. And I think one of the questions that I had received beforehand was even pain. It's another issue. How do you appreciate and access pain through telehealth? So I think this is the type of, again, issue that you will encounter, and there is no simple answer to that. And my recommendations, and also when you look at the literature, is first, you need to have some sort of inpatient contact with your patients. You need to know them to be able to appreciate their symptoms. If during COVID-19 we cannot have this face-to-face encounter, in-person encounter, then you could use the rating scales that are widely out there. They're evidence-based, where like the PHQ-9 we use for depression. I think there's an opioid rating tool to see how likely someone might be to become addicted to opioid based on past history of substance use, family history, personal history. So one thing that I find helpful is to ask patients to use a rating scale. So there are rating scales for pain, there are rating scales to see tendency to become more addicted, and at the end of the day will be a clinical judgment. And in the future after COVID-19, if it's I presume a lot of clinic will continue with video visit. I'll recommend people to start thinking, even if you want to do a video visit, to at least have a ratio of 2 to 1, where you see the patient twice to video visit, but at least the third time have them come in person. And that was the way I usually did it when I was in New York. And I never, if I go a third visit back-to-back video visit, that means something really significant is happening, the patient cannot come in. But usually I ensure that we have certain ratio of in-person and video visits.
Dr. Samir,
yes.
I'm sorry, this is Kate. I hate to interrupt you. We only have a few more minutes left for your presentation, so we can get to the next presentation. Just wanted to give you a time check. Thank you.
Thank you. So other things will be lack of privacy. I've seen a lot of patients having video visits at work. So just ensure that there is some privacy while you're conducting the video visit. Some people go in their car. I've seen patients sitting in the closet because there are other people at home. Miscommunication, be aware of that. Not everybody is cognitively sharp or having some visual impairment. Patient dependency on telehealth. I think that will eventually happen if people are having video visit in the comfort of their home. And other issue, also ensure that you have some sort of boundaries, because with technology comes greater access. Greater access can lead to overreach, where patients might feel they could access or text, send messages anytime. So it will be good also for safety issue to have some sort of time limit, clinical hours. And patients crossing state lines, I think we'll talk about that more with the next presenter. When it comes to health insurance, a lot of students right now are going back home, and unfortunately they cannot access telehealth because we cannot cross line. So what happened is patients of mine who live in Toledo, for instance, they will go to a place in Michigan and provide the address to me, and they sit there to have the video visit. So patients have been crossing line and to get access to care. Next slide. So this one just only summarized the fact that, the people who mostly need telehealth might not get it, unfortunately, and that will happen in cases where there is a lack of access to technology. People are homeless. I've encountered people telling me they don't have a way to charge their phone, or they don't have minutes on their phone. So poverty, social determinants of health, there will be this discrepancy between who really can access telehealth. Although telehealth in its principle was designed and it's supposed to help increase access to those who mostly need it. And even internationally, also there's this discrepancy where some people, they show that a lot of people don't have access to internet, phone, or they don't have enough connection. And one thing to keep in mind, high connection with 3G and 4G, there will not be in those rural areas where there are not enough subscribers for those high connectivity internet, so that's why they might not be there. So one thing to keep in mind when we're designing and implementing telehealth is to make sure that you know your population and know how to work around that. And the other way you could maybe work around that is to integrate or collaborate, have collaborative care where you have mental health and physical care together in a way that patients doesn't have to go separately to see separate providers, but they can have this integrated care. Next slide. So other things, documentation, I will say as usual, make sure you document where the patient is for safety issue and billing purposes. I feel it helpful the way the training could be personalized both for providers and patients. Mass training of telehealth, so far, I didn't find it helpful. I felt that when you can have like a one-to-one, you help better, and especially for patient as well. The patient I presented initially, what I ended up doing when she came to see me face-to-face is I connected her with someone at the front desk who helped her get enrolled in our video visit and practice also and see if she could do it. The other thing to keep in mind, recorded. This is not something that's been widely published, but this is something to keep in mind. So the same way court, if there is any litigation, medical error, and then your notes can be subpoenaed, keep in mind that the video visits also can be asked to see in court. So those are not cases or things that have come up yet, but those are things to keep in mind and be aware of. Next slide. So you already have this document. I don't think we have to really go through all of this. I somehow touch upon those. One thing I will mention is, next slide, it's having this checklist where you know exactly what you want to ask your patient. Always ask your patient and not forget to ask. And one thing that I find very helpful personally is not only to have their address documented in case I need to call 911, especially after hours, but also make sure that you could ask, is there anyone else in the house, something like that. Because I've had patients reporting they had guns in the house. And if there is a safety issue, it's good to have someone else involved and be part of this safety plan. And something else also that helps is at the very beginning, I always tell patients, I might mute my mic if I want to communicate with the clinic, if I want to call them. And that way, if you call 911, like my resident told me last week, she told the patient she was calling 911, the patient was aware of that, the call dropped. So if you call 911 and your mic is mute, it's not unusual. You call 911, they go to the house, and then when you share that with the patient, some providers do not share that with the patient, but once you share that with the patient, at least they're already on their way. And the other thing is, next slide. Again, to keep in mind, we might not feel comfortable the first time we will have video visit with patients. So one thing I find very helpful is to find a way to break the ice. And one thing that's very important that doesn't show at the bottom of this page is it's okay to stop a video visit. Always think, if there is one last point that I want to make is it's okay to stop your video visit. If the patient is driving during the video visit, if the patient is intoxicated, it's okay to stop it. If the patient is very inappropriate as well, it's okay to stop the video visit. And I think the reason I'm putting the emphasis on that is because a lot of providers, they will do it when they're meeting in person with a patient. They will have some boundaries, but through video, through telehealth, it might be difficult to emphasize those boundaries. Otherwise, the other slides you already copied.
Hello, Dr. Severe, this is Kate. I'm sorry to interrupt you, but we really do need to wrap up for our next presenters.
Okay, so I think that's all I have for today. As I said, you already have this document. It has a lot of clinical recommendations and helpful tips. If you have the documents with you, you can look at it, see if you have any questions or concern or anything you want to bring up. But the rest of the slides is mostly the document that I had shared with you.
Thank you. We will be providing these slides as well as some additional information that you provided to us, Dr. Severe. So that'll be very helpful to everybody on the webinar. These have been some great recommendations. So thank you so much. We're going to move on now to our next presenter, Myhen. Mary Graham, I think you're going to start out, Mary, or is it Kim who will start out?
Nope.
We will, we're hoping to get to some Q&A. We're a little tight now on time. So if we don't get to a full resolution of Q&A at the end, please submit your questions to us and we will send the answers out to everybody afterward. We'll do some follow-up. Okay, thank you, Mary. Welcome.
Thank you very much. And I want to thank everyone for joining us today. Kim and I have done this quite a bit where we can go quite quickly so that we can entertain your questions. Kim and I are from Michigan Health Information Network, which is, in fact, next slide, please, the state designated entity to organize and deliver essential clinical data that needs to move outside or across the EMRs, the health plans, and the health systems. Affiliation with Great Lakes Health Connect at the end of 2019 brought the skills and existing interfaces of the biggest HIE in Michigan to Myhen, which is a huge win for the state of Michigan. Next slide, please. And I think everyone can hear me. Just someone speak back and confirm. Well, yeah, obviously the slides are moving, so yes, you can hear me. Sorry about that. State designated entity that is, let's see here, moving on. This slide should be impressive for you because that is in fact the state of healthcare, health information exchange in the state of Michigan. But the beautiful part about it is Michigan Health Information Network is in the center, serving as a hub and allowing all those folks to connect to one source, one entity, rather than to each other in a spaghetti-like fashion. So that it promotes efficiencies and provides data exchange, getting information at the point of care and time of service as needed. Next slide, please. May I have the?
Sorry, it's
Thank you.
very big delay here.
Right.
And
yeah, and that one doesn't look quite right.
yeah,
I can just speak to it rather than worry about it. Okay, and here it comes. The primary way that Michigan Health Information Network supports the state and their citizens is through promoting use cases which normalize and standardize elements of healthcare. And with the spaghetti slide you saw before, you know that there's an awful lot of different investments and different services and different protocols and ways of doing business. And so in order to normalize that and standardize it, we use an incremental and developmental approach to transformational care. We want to change all of those ways of doing business to make them work for everyone, but we need to take baby steps to do that. Some of the use cases are very simple and almost invisible to the users, and others are a bigger lift. So what you see on the far left is our the use cases that are conceptual, they're in development, and we're just getting them started. As we move to the right, you see that we have other use cases that are already in flight or in mature production. Some of you are familiar with one of our foundational use cases, which is the advanced care, advanced care directives. Nope, sorry, misspoke. It's actually the admit-discharge transfers, which is driven by the active care relationship service. Next slide. And of course, two things that I want you to see from this slide, and then I will hand it off to my colleague Kim, is that we welcome and want the input and engagement of our stakeholders for use cases that they believe the state needs to start to embrace or consider. And then that the use cases themselves are not static. We use the cycle of continuous improvement to develop and grow the use cases over time. And now I'm happy to hand this over to my teammate Kim, who is going to start us off with where we're going with telehealth as a use case, and then I will talk a little bit about services and ways to do and ways to pay for and all the other things you're interested in around telehealth.
Thank you, Mary. If we can go past to the next slide. Awesome, thank you. Again, thank you for inviting us. There's really two components we would like to discuss with you today related to our telehealth design. And the first is the creation of a statewide telehealth use case. And the second is our work centered around providing a telehealth service to support our stakeholders. Within this current slide that you are on right now, we all are aware there is a rapidly growing environment around telehealth due to the COVID crisis. We also understand that the healthcare community is inundated with incorporating new telehealth solutions to assist with continued care and treatment of their patients under the social distancing rules. However, we feel at MyHIN there is a need to incorporate these new telehealth solutions into the healthcare ecosystem and involve the patient and provider experience and workflow created by this telehealth boom. Therefore, we are exploring ideas on a statewide use case that will drive access, care coordination, increase patient engagement, transitions of care, and will support public health priorities. Ideas that we're exploring are around data that can be incorporated into the telehealth platform that will ease the burden off the provider and enable better care coordination by integrating telehealth platforms into the workflow process, so there are fewer screens to interact with and less duplicate effort. We are also exploring ideas on how to increase patient literacy, education, and engagement by encouraging integrating patient-provided information and patients' access to their information within telehealth systems. We're hopeful we can build off and grow patients' use of telehealth from the COVID experience and encourage more interactive patient and provider engagement. This includes sending virtual visit information to the EMR and other information gathered during the virtual visit if the telehealth platform or provider is not included in the patient's active care team or connected to the EMR the provider is using. We are creating a telehealth registry, which is pretty exciting, that tracks access points to providers' preferred telehealth system. This will enable a more seamless experience for providers and patients when initiating virtual visits, kind of lessening the burden off of patients to try to find where to go to access the system that their providers using to initiate virtual visits. We're also exploring what HIE statewide use cases will be valuable in solving issues or concerns about the telehealth experience during COVID, and of course, promoting public health efforts and mandates. Next slide, please. What we are seeing from survey results that were graciously shared by Blue Cross Blue Shield recently surveyed 40 Michigan provider organizations consisting of a mix of primary care and behavioral health practices. The 226 out of 2,384 practices, or 9.5% of those practices surveyed, were engaged in telehealth pre-COVID. We also know pre-COVID there was a various types of services related to telehealth adoption. And adoption has been slow and not seen as a priority because in-person care was the standard and supported form for a patient's visit. We also understand that there is not standardization or normalization for payments or regulations. Each state varies. For example, Michigan Medicaid reimburses for live video for certain healthcare professionals for patients located at certain originating sites for specific services. There's no reimbursement for store and forward or remote patient monitoring, while other states like Texas Medicaid reimburses for live video and storing forward in some circumstances. Home telemonitoring is reimbursable in Texas for some conditions when a provider is approved to deliver those services. So it causes a lot of competitive and disorganization in the market. Mary, you want to share your thoughts on the telehealth landscape during and after COVID?
Sure, because our time is compressed, I'm going to focus everyone's attention on the very last statement on the right, which is we see telehealth moving in the direction of really being embedded into the patient-centered medical home and the community. This will promote the incentive programs, backing them. The health insurance companies really are engaged in this and have been for a while, but they have had to resort to sometimes using a contracted vendor system as opposed to using the PCMH. Once the PCMHs have all embraced the service and the healthcare community in general, I think we'll all be on the same page working towards the same end. Next slide, please. There we go. One of the things that I know that everybody was interested in seeing was what kind of resources can you offer us? Well, I offer two here relative to current law, regulation, and billing. And the first one is, of course, the government, which changed a lot when COVID hit and said basically relative to their product, which was the Medicare, they wanted to make sure that you knew what you could do in order to meet clients and take care of them where they were. The second resource is the Upper Midwest Telehealth Resource Center, and I have listed a number of resources and also shared them as documents that you can get from Nikki. The Upper Midwest Telehealth Resource Center is sort of A to Z on all things telehealth. They are a free service, government sponsored, and they take care of a 4-state catchment area. They're responsible for making sure that information is available. You'll see 3 different references there. One's general, one's COVID specific, and one is telehealth billable specific to Michigan. So I do recommend that you look at those. Can we have the next slide, please? There we go. Care Convene is not a use case. We talked a little bit about use cases. It's a service. Other things that MyHIN is going to be offering over time are also services like Viper and Bridge for those that have it. Those pesky timings. That's not your fault, Nikki. Timings are always pesky. I agree. Don't know why that had that. So it is a service. It is going to be supported by our help desk, so we can support both the provider and the patient. It is actually patient and providers facing, which is slightly new for us. We've always been provider to provider. And it's a place to do business. The patients are actually going to get engaged. We'll stay here now. That's fine. And you have 2 ways of working at it. If you're a provider, you can work on the website, in other words, in your computer, or you can also work on your phone, and you'll see different ways of looking at it. When we talk about the Care Team Viewer, that means that doctors are not the only ones engaging with patients. Case managers can, social workers can, anybody that the practice. It is a practice supporting tool, and it is also obviously HIPAA compliant. Can we have the next slide? Now it won't go because we wanted to. There you go. It supports the PCMH. This is a differentiating factor. When you look at something like Amwell or MD Live or Teledoc or Zoom or any of the others, they're basically just a way to engage the patient in a Zoom sort of schedule and engage the patient. This is a very robust tool that is practice centric, and it is going to engage the patient around their conditions, around their discharge symptomology and monitoring, around their getting patient literacy. And it can also be HIE enabled so that you can be working with the different use cases and get the services through that. So next slide. Yeah, we went the wrong way. There we go. So 3 examples real quickly. Patient behavioral health visit. So they're going to pick their symptoms on the left. They're going to identify, whoa, that went fast. They're going to identify their symptoms in the middle. Then it's going to go to the waiting room. And then this particular is a chat visit. So if the patient did not want to engage in video or phone, they can have a chat visit. Now we'll go to the next slide. This is chronic condition management. So in this case, they had CHF and it was post-discharge. They're going to be monitoring their symptoms and they're going to alert the case manager. So the case manager can go ahead and get back with them. It's okay, Nikki, we're going to keep going. And this one is specific to COVID. So in the very lower right bottom box, you see a, whoops, go back. You see COVID symptoms. They would pick their symptoms. The symptoms would go to the physician or the physician's care team members that are supporting them. And then they would engage the patient. It can be patient initiated or it can be provider initiated. And it can be chat, phone, or video that is customized to the practice. In other words, practice can develop some, their own branding and their own symptom management. For instance, if it's an orthopod practice and they're doing post-discharge symptoms that they want to watch the incision, they could do that. Next slide. And we have it tiered at 2 levels of the product. So if all you want is being able to deal with a practice-centric telehealth service, you can have that. If you want it HIE enabled, so you can participate in all the use cases, that's the Care Convene integrated. So 2 tierings priced at a practice level or a different model if that's what you're interested in. But the reason we're taking a minute to talk about this is we realize in the heat of COVID, you're having to do what you have to do. But once you find out that, once you go, okay, that crisis is over, now I want something that I can use long-term to meet the needs of my practice and my patients, then these are the kinds of features that you want to be looking for, we think. And they will also be sort of what we're building our use case around. So I think that's pretty close to where we're getting done. Could we have the next slide? Yeah, this is just our contact information, and that left us, I talk fast, and I don't think I've ever talked quite that fast. So I think we have 3 minutes for questions.
Thank you, Mary and Kim. You did a great job in a short amount of time. I appreciate that. It was very informative. I learned a lot. Interesting that you mentioned Zoom, because one of the questions we did have is commented that there was an article in the New York Times yesterday that said Zoom and similar platforms may not be good tools for communicating.
Stand.
Okay. Yeah, whatever my doctors have used has been, it's got the waiting room. I'm not sure exactly what it is, but it's worked out well. We also had a comment from Kristen Spangler, and Kristen said that they start their calls and videos asking where the patient is today, and that supports licensing as well as safety. So I think that was a really good comment to share. We are going to send out the slides and the additional materials that Dr. Severe has provided to us. We encourage all of you. Unfortunately, we didn't have time to get to your dialogue, which we wanted to be able to spend some time getting feedback from all of you as well. But we are encouraging you to send questions and comments and feedback to us via email. You can respond to the email you received from Nikki, and then we will summarize those and send out a summary to everyone who was on the call. You know, just from my perspective, I was surprised when Dr. Severe talked about the 20% improvement in health outcomes. Again, thank you to everyone. Thank you so much to our presenters. Thank you to Nikki for coordinating this. And everybody, please stay safe and have a peaceful weekend. Thank you again.